It's a pleasure to be able to speak to you all today. My only regret is that I cannot be there with you in person, nor am I available to answer questions. Nevertheless, I hope that you will find something useful to take away from this talk, which is on how to deploy fascial plane blocks in general to treat acute pain syndromes. I'd like to start by reviewing what fascial plane blocks are and the principles of how fascial plane blocks work as we currently understand it. Fascial plane blocks are an injection of local anesthetic into a potential space or plane that exists between two layers of fascia. And this is most commonly the perimysium of muscle or the periosteal covering of bone, and sometimes even the ligaments that bridge adjacent bony structures. These hyperechoic linear fascial layers can themselves be composed of multiple individual layers of connective tissues, so they aren't always simple structures. We inject local anesthetic into this potential space or plane, and the sandwich of fascial layers contains and constrains the spread of local anesthetic, influencing where it spreads and it disperses to in the first instance. What we're trying to do in all cases is to target nerves that travel within the fascial plane of injection, or nerves that lie in other fascial tissue compartments that connect with and are continuous with the plane of injection. Now, because the nerve targets are not usually right at the needle tip, unlike with other peripheral nerve blocks, the distribution of local anesthetic is an important factor for efficacy. And this distribution or dispersion is driven firstly by the injection pressure, and we see that as a splitting and opening up of the potential space between fascia as we perform our injections. But thereafter, the elastic recoil of the tissues, as well as muscular contraction and sliding movements, will further massage and distribute the local anesthetic. And we often see this as the pocket of local anesthetic rapidly dissipating, particularly if we continue to scan the area after the injection is complete. There's also a slower second phase of distribution, which is diffusion of fluid through the different tissue layers and then finally across the epineurum of individual nerves and neurons to produce ion channel blockade. This movement and the mass of drug that reaches the target nerves is driven by the effective concentration of local anesthetic molecules. And this slower phase of dispersion can be seen here in an MRI study of tap blocks, where there was an increasing area of visible contrast spread over up to 6 hours. In practice, I would therefore say that we should expect that the full extent of the clinical effect of any block may well take over 30 minutes, and perhaps even longer, to fully manifest itself. So where exactly is all this local anesthetic working to produce a clinical effect? One side of action, I think, is the peripheral nerve endings in the tissues at the site of injection. And we see in imaging studies of the ESP block, for example, that a lot of the local anesthetic distributes within the surrounding muscles. And we can then expect that it will block nerve endings within the muscle. Now, muscle pain, as we all know, can be significant, and it's a big factor in tissue injury. This may be one reason why blocks performed close to the site of injury, like serratus anterior plane blocks in chest trauma and rib fracture, or rectus sheath blocks in abdominal surgery and incisions, as well as the ESP block for back pain. That's why they can actually work quite well. Now, as we said at the beginning, local anesthetic will also reach and act on nerves that are traveling through the plane or compartment of injection. And this is the basis for blocks such as the interpectoral and anterolateral abdominal wall blocks. Finally, local anesthetic may also travel beyond the plane and compartment of injection through communicating channels and enter into adjacent tissue compartments where relevant nerve targets lie. And this is what I think accounts for the effect of the paraspinal blocks, such as the ESP and intertransverse plane or ITP blocks. They exert an effect on the spinal nerves in the foraminal and paravertebral spaces, even though this is not where the actual site of injection is first occurring. Now, Peter Marhofer has highlighted a fundamental limitation of fascial plane blocks compared to more conventional or traditional nerve blocks. We're not actually injecting directly around nerves. These are indirect blocks, and they rely on spread of some of the local to the desired targets. However, I want to call your attention to the fact that even when we do perform direct nerve blocks, such as in this example, a supraclavicular brachial plexus block with triple injections, and we do this aggressive needling and injection, you still observe incomplete blocks. And just bear that in mind when you hear people criticizing fascial plane blocks for their apparent lack of detectable sensory block. Block failure happens to us all with all blocks. Now, with fascial plane blocks, remember, because we're not targeting nerves directly with our needle, only some of the local anesthetics injected is expected to reach the nerves. And the key word here is some. Only a fraction of local anesthetic will get to the neurons of interest. However, the small amount and the low concentrations that result around nerves can still produce a degree of conduction block, because conduction block is not an all or none phenomenon, but a continuum. Small unmyelinated fibers that transmit most of the nociceptive impulses to the dorsal horn of the spinal cord are also more susceptible to local anesthetic action. And then they produce what we call differential block of different sensory and motor fibers. And we see this often with the onset of any block or with the use of dilute epidural local anesthetic solutions. And this sets our expectations for the neuroblockade that we expect to see with fascial plane blocks. It's usually incomplete sensory blockade, but yet analgesia that's often good enough. And the benefit that comes with this is that we can often also get motor-sparing analgesia. And with the paraspinal blocks, we also don't usually see hypotension from profound sympathetic blockade. So I think fascial plane blocks should be viewed in terms of these characteristics. They can be learned and performed by less experienced operators, being simple and safe. You can use them in a wide range of situations, and they usually provide a degree of analgesia that, while it isn't perfect, is often good enough. Now, further considerations, especially when deciding on specific techniques to use, are the fact that catheters can usually be easily inserted in these locations. And this is important as we often want to prolong analgesic duration beyond the 10 to 12 hours of a single shot block. You should also think about how convenient they are to perform, especially when it comes to patient positioning and access to the site of injection. Now, in the remainder of this session, I'll briefly review the techniques of fascial plane blocks in common clinical practice. I'll start with the ESP block, and this was chosen as a Plan A block for the thorax, really because of its relative simplicity and safety, as well as the existing evidence for its efficacy. One of its biggest advantages, however, is that it's like a Swiss knife. While it may not work as well as a specialized tool, it'll generally get the job done if it's all you have. Another big advantage is that compared to some other more anterolateral truncal blocks, it provides visceral analgesia. Local anesthetic spreads to the dorsal root ganglion, which is where the visceral afferents converge with the somatic afferents. Really, the main drawback, as I see it, with the ESP block is that you have to somehow access the patient's back, which means it's not a block you can do in the supine position, and you have to either turn patients lateral or prone, or you could sit them up. Now, I've already said that it's versatile, and this is one of its great strengths. You can perform it at different thoracic vertebral levels, and so you can target specific thoracic and thoracoabdominal nerves of interest. There isn't just one or two specific clinical applications, and the basic technique is the same no matter what level you're targeting. But what you do need to think about is whether you want to cover the posterior or anterior torso, because then the technique will differ. I have described this in more detail online, but briefly, if we're interested in just covering the posterior torso, then the original technique we described, where you target and land on the bony transverse process and look for linear spread under erector spinae muscle, is very much one that holds true. If, however, we want coverage of the anterolateral torso, then we now need local anesthetic to clearly penetrate into the region of the paravertebral space and the intervertebral foramina. This penetration is maximized by depositing the local anesthetic under the deep fascia of the erector spinae muscle so that we're minimizing the distance and the barriers to spread towards those spaces. I therefore now recommend that you should not aim to land squarely on the transverse process, but rather to target the edge of the transverse process, so that if necessary, you can slide a little deeper off it and look to see that injection is clearly occurring under the erector spinae muscle rather than within it. We do not want to see intramuscular spread or expansion. And if you do, that is a cue, as I've said, to slide that little bit deeper and look for this clear lifting of the muscle, as you see here. One technical and anatomical point for successful ESP blocks that hasn't been emphasized much to date, but that I do think is important, is not just where you're positioning the needle tip with regard to the anterior-posterior axis, as we've just talked about, but also the medial to lateral axis. We now know from micro-CT imaging that there are these two gaps that link the retro-SCTL, or superior costotransverse ligament, and paravertebral spaces. The medial slit, or what others call the costotransverse foramen, is the closest passageway connecting the ESP and retro-SCTL space, as well as the proximal paravertebral space, where you can see that the spinal nerve root is emerging from the neuroforamen. So, we must pay attention to the exact parasagittal plane that we're imaging and needling in terms of whether we're more medial or lateral. And nowadays, I would generally recommend not necessarily trying to target the very lateral tip of the transverse process. Because what often happens when you do this is that you can end up even more lateral in the plane of that rib transverse process articulation. And this is also where you get this nice bright image of the bony surface of the proximal rib and the pleura, and perhaps even sometimes the SCTL, or superior costotransverse ligament. And it looks good. However, it's important to recognize that this is significantly more lateral. And as you can see here from this intertransverse process view, it lowers the probability that local anesthetic is going to reach the proximal area of the paravertebral space, where the high-value targets are, the dorsal root ganglion and the spinal nerve root. Rather, the local anesthetic is likely to be in the more sort of proximal intercostal space. So I think particularly if you're aiming for visceral analgesia, it does make more sense to image and advance the needle in the parasagittal plane that is closer to the base of the transverse process rather than its tip, what some might also call a paralaminar plane. And in practice, this means looking for a plane in the parasagittal view where you still see the squared off shadow of the transverse process, but where the pleura and the SCTL, or superior costotransverse ligament, are barely visible, if at all. And in this more medial parasagittal plane, any injection under the erector spinae muscle, which are the red triangle, you can now see is closer to that medial slit or costotransverse foramen, and this increases the probability that we'll get spread into that proximal paravertebral space and the intervertebral foramen, rather than the intercostal space. So to sum up, I would generally recommend that you should try and obtain the lower image, the lower ultrasound image that's highlighted in red, rather than the blue one. I'll end this talk by briefly discussing some of the choices for fascial plane block techniques that are going to be based on the anatomical region that you're interested in blocking. Now, if you're looking to cover the shoulder region, you can perform an ESP block at anywhere from the C7 to the T2 area. However, I don't think it should be the first line block in most shoulder surgeries. Now, if for any reason the brachial plexus is not accessible or suitable, then it is a good option, and it has been described for things like a 4/4 amputation, and I've also found it useful in certain scapular surgeries. When it comes to thoracic surgery and thoracic trauma, if you cannot or do not want to do a thoracic epidural or paravertebral block, then the two choices here are a thoracic ESP block or a deep serratus plane block. There's good evidence to support both, and I would say that the deep serratus plane block is particularly easy to do. It's also often feasible in the supine position to cover the anterolateral chest, so it can be more convenient to perform than an ESP block. I should just mention that the QR codes on some of these slides will take you to other videos that outline the specific technique in more detail. Now, abdominal wall blocks are a little bit more complicated in terms of deciding which to do, and I'm going to refer you to a talk that I've previously done which addresses this question. But the first thing to always ask is, which spinal nerves are you interested in, and more specifically, are you trying to cover the upper or lower abdomen? If it's the upper abdomen, then I think these are the current options as I see it. Now, you're interested in the T6 to T9 or 10 branches, and other questions you should ask yourself is whether you're trying to cover the anterior or lateral aspects of the abdomen or both, and whether visceral pain is going to be a big component, because visceral analgesia can only be provided by a paraneuraxial technique. And the same considerations apply to making a specific choice around blocks for the lower abdomen. Again, we have these few options that will allow us to cover the T10 to L1 spinal nerve segments. And again, ask yourself, do you need visceral coverage? How far lateral do you need the coverage to extend? Do you need then to cover the lateral cutaneous branches of these spinal nerves? Where's the incision? Where are the wound dressings? And can you therefore position the patient and access the area to perform the block that you want to do? If we move on to the hip region, there are also several choices for fascial plane blocks, although you may not have thought of them all as fascial plane blocks. Now, when you're trying to choose between techniques, consider where the pain is arising from. Is it the bone, the joint, ligament, or muscle, or a combination of both? In addition, ask yourself whether motor block is relevant. So, you can do periarticular fascial plane blocks around the hip joint, like the PENG or the iliopsoas plane block, which both have a lower risk of causing any quadriceps weakness, and they mainly target the hip joint itself and surrounding bone. Or, particularly if muscle is a bigger component, you can also perform the classic fascia iliaca block, which may be the earliest fascial plane block ever described. Just remember that there are different variations of this, and not all fascia iliaca blocks are the same. You can do infrainguinal in-plane or out-of-plane or suprainguinal fascia iliaca approaches. But in all cases though, based on the anatomy, it's my opinion that it's critical to produce spread towards the lumbar plexus, so the direction of needle insertion and injection, as you see here, should always be in a cranial direction, because this will produce the maximum amount of spread towards the targets that we're interested in. And finally, the last technique I want to cover is a lumbar ESP block, which is something you can do if a posterior approach is feasible and desirable. Say, for example, that you want to place a catheter that remains out of the way of the surgery. I won't go into a lot of detail, but if you're interested to learn more, see my videos on the block and the anatomy that I've produced online. Essentially, however, what we're trying to do is perform a lumbar plexus block by proxy. And you can see from the cadaveric section that lumbar nerve roots lie just deep or anterior to the fascial border that separates erector spinae and psoas muscle. So, by performing an injection just deep to this visible hyperechoic fascial layer using a parasagittal view of the lumbar transverse processes and in-plane approach, we can drive local anesthetic towards the lumbar plexus and lumbar nerve roots where they are embedded within the psoas muscle. That concludes my talk for today. Thank you once again for the opportunity to be able to speak to you all today. I wish you a very enjoyable and successful remainder of the conference.
Olá, pessoal. Bom, depois dessa brilhante aula sobre bloqueios interfaciais, estou aqui com o Dr. Lino Dias para fazermos um debate, uma discussão sobre o assunto. Estamos abertos a perguntas, só enviar aqui no nosso chat, que assim que recebermos, nós poderemos fazer uma discussão e também abordar o assunto. Bom, Lino, eu particularmente eu gosto muito desses bloqueios interfaciais, faço bastante também e na prática diária, principalmente esses bloqueios de tórax, né, o ESP block, todos nós, eu acho que realizamos no nosso dia a dia. E uma coisa que eu achei bastante interessante nessa aula, inclusive foi um aprendizado para mim, foi a abordagem do ESP block, que ele recomenda essa abordagem lateral para medial. E é uma prática que eu já exercia, por recomendação de um outro sócio meu do serviço, que quando eu acompanhava o serviço de dor do sírio-libanês, eu via que, para esse anestesista especificamente, as cirurgias de tórax, quando ele fazia o SP Block, tinha um resultado de uma analgesia visceral um pouco melhor. E aí eu comecei a usar essa prática. Você utiliza essa prática no seu dia a dia de abordagem do bloqueio SP Block?
Bom dia, Márcio. Bom dia a todos. Márcio, eu uso muito o ESP né, para cirurgias torácicas, até minha prática diária atualmente é um pouco menor, são bem mais raras, mas eu uso muito, e uma coisa que, conversando com colegas aqui que gostam, eu sou muito fã do ESP Block, eu comecei a utilizar, por exemplo, são meus pacientes que parecem uma bobeira, mas, por exemplo, cirurgias plásticas, por exemplo, que a gente tem que ter uma cobertura muito ampla, muito. A gente precisaria de um bloqueio de neuroeixo muito extenso, aqueles catéter peridural, o paciente ficar muito com sintomas de bloqueio simpático muito agravantes. Então, por exemplo, eu tenho utilizado o S-Block em cirurgias assim. Bloqueios faciais, que você falou na minha prática diária, são relevantes. Hoje, com o crescente de cirurgias videolaparoscópicas, por exemplo, a gente tem tido bons resultados com bloqueios de parede abdominal, por exemplo, você vai fazer uma hérnia por vídeo, umas cirurgias de andar inferior do abdômen. Então, eu acho que, assim, apesar do pessoal esquecer que o TAP da baía do reto, postal, ficaram meio que no passado com os adventos dessas novas técnicas, eu ainda continuo usando todos eles, né? E como você falou do eretor, eu nunca fiz tão medial assim, eu realmente sempre fiz no processo transverso, mas sempre a ponto de eu não ver a costela, então eu acho que no meio termo do ponto que ele falou do medial, né? E uma coisa que eu sempre fiz foi nunca bater no processo transverso, sempre fazer entre os processos transversos o que ele recomendou também, que como ponto de punção, né? Então o eretor, assim, eu vendo aquela separação adequada da bainha, do músculo do músculo intercostal com o músculo eretor da espinha. Né? Então eu sempre tive o cuidado de nunca bater no processo transverso, sempre fazer entre os dois processos transversos. Né? Esse foi um cuidado que eu sempre tive. E aí eu tinha realmente uma qualidade no meu ponto de vista, lógico, né? Isso eu nunca contabilizei em termos de trabalho científico e nada, mas a gente vê que uma qualidade superior.
Legal. Eu vou até citar esse meu colega, o Bruno Tonelotto. Ele faz bastante tórax no nosso serviço e acompanhando a analgesia no pós-operatório dos pacientes de dor de uma forma geral, eu vi que ele passava o catéter de lateral para medial com o probe na posição horizontal, né? Ele via todo o processo espinhoso, processo transverso, e passava o catéter no processo transverso com a ponta do catéter lá bem medial, quase ali no início do processo é, espinhoso. E aí, agora vendo a aula, eu achei que é muito interessante isso, porque ele bloqueia o gânglio da raiz dorsal. E esse bloqueio do gânglio da raiz dorsal dá essa analgesia visceral. E aí eu achei finalmente uma explicação científica para esses melhores resultados, né? E eu tenho adotado essa prática. Eu não sei se existe algum trabalho na literatura, inclusive, sobre esse posicionamento de catéter em SP Block, mas eu, particularmente, acompanhando os pacientes de dor, eu observei um melhor resultado com esta técnica, tá? E seguindo na mesma linha da aula anterior, Lino, que a gente tinha feito com o Leonardo e o Rodrigo, você tem utilizado adjuvantes nos bloqueios interfaciais?
Ô Márcio, respondendo essa pergunta sua, deixa eu só responder aqui. Perguntaram qual seria a diferença que ele citou entre o local da injeção do S-Block, né? Só para responder essa pergunta rapidinho também, e responder as duas ao mesmo tempo. O local da injeção, segundo o que ele falou, foi a gente buscar a injeção mais próxima ao espaço que teria, uma abertura que teria no ligamento costo-transverso. E essa abertura seria mais medial do que lateral. Então, quando você faz uma injeção mais medial, a justificativa dele teria uma dispersão mais assegurada para o espaço paravertebral. Por isso, uma injeção um pouquinho mais medial e não uma injeção um pouco mais lateral. E eu vejo muito erro de técnica no eretor justamente isso. O pessoal faz tão lateral que ele acaba fazendo basicamente um plano intercostal. Uma sobre adjuvância, até passei a pergunta na palestra anterior para o Rodrigo, sobre a dexmedetomidina. Eu tenho usado, assim, na prática perineural, eu evito o máximo a adjuvância, porque a gente vive hoje uma crescente de judicialização da medicina. Então, assim, apesar de ter alguma coisa de vazamento científico, perineural eu nunca boto adjuvância, mas nos faciais, se eu não vou utilizar catéter, eu utilizo adjuvância sim. Eu gosto muito de usar a dexmedetomidina, que eu acho que tem um bom embasamento e uma segurança hoje boa. Então, assim, toda vez que eu vou para um plano facial, eu tenho o hábito de usar adjuvância. E o que que eu vejo? A gente prolonga a analgesia para 18, 24 horas. E é o que eu falei, eu sempre dou um feedback para meus pacientes, eu gosto de conversar com meus cirurgiões, com o próprio paciente no dia seguinte das cirurgias. Eu gosto de fazer essa visita pós-anestésica para saber como é que está sendo a minha conduta. E o que que eu tenho visto? Você segura uma analgesia satisfatória e depois a analgesia multimodal, oral, que o paciente vai manter, dá um conforto muito bom. E realmente o que a gente vê, eu converso com meus pacientes, que o dia pós-operatório tá bom e ele vai ver o que é dor somente no dia seguinte, né? Então eu acho que, para mim, a adjuvância nos bloqueios faciais me ajuda bastante, porque eu acabo não colocando catéter, são cirurgias que o paciente vai embora rápido, né? Então eu não quero fazer uma infusão de anestesia local e mandar o paciente para casa. Então eu faço basicamente o single shot.
Não dá hipotensão?
Não tenho não, Márcio. Tipo, eu tenho feito sempre pré-cirúrgico, eu faço antes da cirurgia, estou sempre associado a uma anestesia geral, né? No meu caso, eu gosto da cirurgia geral venosa, então eu consigo controlar bem meu paciente. É, no eretor da espinha, se eu faço grandes volumes, eu acabo fazendo um pouquinho de bloqueio simpático, mas nesses faciais mais anteriores, tipo tap block e o subcostal, esses outros, eu não tenho tido hipotensão. Porque eu tenho uma bradicardia que eu via muito mais frequente que os trabalhos realmente mostraram com a clonidina. Que antes de eu ter acesso à dexmedetomidina, eu usava muita clonidina, e realmente a bradicardia era intensa. E a hipotensão também. A dexmedetomidina deu uma estabilidade bem, assim, no meu ponto de vista, adequada. Eu achei que hoje é satisfatório. Eu raramente eu corrijo bradicardia ou hipotensão do meu paciente que não seja devido à anestesia geral em si.
Tá certo. Lá no nosso serviço, a gente utiliza também dexametasona no bloqueio periférico, tanto esses interfaciais quanto perineural, né? Mas principalmente esses interfaciais, a gente andou estudando alguns artigos sobre cronificação de dor e sobre melhor desfecho em médio prazo, né? Então a gente também tem associado dexametasona, né? Dexametasona nos bloqueios periféricos. Nunca tive nenhuma complicação decorrente disso daí, não.
Você tem usado dose alta ou dose baixa?
6 miligramas mais ou menos de dexametasona em um volume de 30 ml, assim, né?
É baixo.
Nesses bloqueios que utilizam um volume mais alto, né? 20 ml, né? 20 ml de roupa a 0,375 a 0,5%. Bom, pessoal, deu o nosso tempo aqui. Agradeço a participação de todos e vamos seguindo nesse simpósio que temos temas muito interessantes ainda a serem tratados. Obrigado e um abraço.
Muito obrigado a todos, muito obrigado novamente, Saesp. Parabéns pelo evento que está sendo executado.